Hello, everyone. This is Dr. Mary Lauder, and you are listening to the Since You Put It That Way podcast. It's the show that examines various health, wellness, and medical topics from unique perspectives. We will be having discussions and guests that will cause you to pause and consider, well, since you put it that way. Hello. Thank you for joining us on Since You Put It That Way. Our guest today is Dr. Megan Pass. She is a physical therapist, a doctorate in physical therapy from Duke University. Her undergraduate's from Michigan State University here in Michigan. And she practices here in West Michigan, over here by me in Holland, Michigan. And she's going to be with us for a series, or I would dare say ongoing conversations. Today's conversation, however, I'm going to pull up my notes here, is about the introduction to what physical therapy is. What do physical therapists do? What should we know about physical therapy and how to choose a good physical therapist? So without any further ado, here's the conversation that Megan and Mary had regarding physical therapy. Thank you for joining us and enjoy the conversation. Well, welcome, Megan, to Since You Put It That Way, our podcast that makes everyone stop and pause and think, well, since you put it that way, let's think about that. So welcome as we get ready to go into conversation about physical therapy. You're a physical therapist. Why? How'd you get there?
How would I get here? What a great question, Mary. And thank you. Thank you for this opportunity to share my story and the story of a unique story into physical therapy, actually. My story into PT is just like almost every other physical therapist. I was a chronically injured athlete who was nicknamed Ford by my personal trainer, fix or repair daily, three-sport varsity athlete. And I never let my injuries stop me. But that also then led to some great compensation patterns later on in life. And so my athletic trainer at the time in high school was blessed to have an athletic trainer dedicated to our high school.
Yeah.
Our local hospital paid for this service for the area school districts.
Yeah.
And I was like, well, I want to be an athletic trainer. And he was like, no, you're too smart for that.
Yeah.
And thank you, Chuck Middleton, who is now a doctor of physical therapy as well in my hometown. And it just catalyzed me into this path. And so went to school, Michigan State for my undergrad, even knowing I wanted to be a PT, but definitely explored some different avenues. My undergrad is in nutrition because I found that fascinating. Not the dietetics nutrition, but nutritional sciences. So the metabolism of the body.
Right.
And then I ended up at Duke doing physical therapy. And so spent 3 years through their program and graduated as a doctor of physical therapy.
Yes. Duke is not easy to get into. So you have to be a bit nerdy, aren't you?
I'm a total nerd.
Okay. Nerds rule the world, really, at the end of the day.
They do. I'm a total smarty pants and I have no idea how I retain information or facts, but it happens. So okay. Here we are.
Well, I have a funny story about physical therapy because I'm one of those athletic trainers. And so my undergraduate at the University of Montana was in athletic training. And I loved it and I excelled in it and got like 4-point in it. And so I thought of going into physical therapy because our programs were combined. So you applied to the professional program and then you got into athletic training. And then my second year in athletic training, I thought, well, I think I'll consider physical therapy would be an add-on year and then go from there. So I talked to the director of the physical therapy program and she set me straight. I simply was not physical therapy material, she said. And the funny thing is, my advisor, when I first started at the University of Montana, said, oh, you need to go be an osteopath. To which I said, oh, no, they're quacks. And there's a story about why they're quacks, or I thought they were quacks in my book that's coming out later this year. So I'll hold those details. But I certainly was of that mindset in undergraduate. So quacks on one side, not physical therapy material. So then I go to Michigan State for graduate school for athletic training. I get fascinated by spinal biomechanics. And then I find out in osteopathic schools at Michigan State. I applied
Mhm.
to one osteopathic school of all the schools in the nation, and what happens? I get in and I'm an osteopath.
You know what? That story cracks me up because there's an interesting parallel there. So I was going to apply to the athletic training school at Michigan State for undergrad, knowing it was one of the top ones in the nation and the ATC PT combination would be gold.
Yeah,
But I was in the marching band at Michigan State and I didn't want to give that up.
yeah,
Total nerd here.
a band nerd to boot.
Band geek right here, right
Yeah,
here.
yeah. Oh, that's hilarious. And so then I swung back around when I visited Missoula when I was in medical school, and I found that department chair and shared the delightful news that I was so glad that I wasn't physical therapy material after all. And I agreed with her because I'm a doctor.
Well, you know what? I have like such respect for physicians because the reason I didn't go med school because I was pre-med undergrad. The only
Yeah,
reason I didn't go med school is I just can't handle the pain and the suffering and that like acute aspect of care. And so I can't tell you how many times I end up on the floor observing and all sorts of stuff. So that is like why I'm a PT
yeah,
and have gone the route I have gone. So I have so much respect for physicians in the way that they are able to hold that and be a
yeah.
part of that process because that is not for me.
Yeah, and what's interesting is the rehab part. I'd be like, seriously, can we just get there? So I'm like at the other end of that, ready to diagnose, treat, do the surgery, put them back together. I'll sew them, fix them, bolt them, screw them up. All right, they're all yours now. Off you go. I see my work here is done. So, so, oh my goodness. So it's really funny. And we found too, without going into details, how different, parallel, the same our lives have been and our interests are. And so that's one of the reasons that we're connecting now and collaborating with both physical therapy, osteopathy, healing, transformative care for all aspects of any person who's interested, mind, body, and spirit. So, yeah,
Yeah.
so it's just so funny. So, all right. So then now, when people talk about physical therapy, though, and they literally think they're going to go and just get an exercise program. They're on a treatment table, they're left alone. And I hear that a lot still now. Well, as I go and do, they give me exercises and they don't do anything. I don't even know if people are doing the exercises right.
Yeah.
But tell me about the different physical therapists, the different roles, acute care, chronic care.
Mhm.
Really give us a tutorial of, an overview of physical therapy.
Yeah. So physical therapy was actually founded in the Second World War through convalescent nurses
Okay.
and working with injured soldiers and helping them convalesce and rehab back to function, essentially. And so knowing that that's where physical therapy started, it's an easier way to look at our role, essentially. Whether our role is in the hospital of getting someone up out of bed or getting them to learn how to re-roll in bed, to sit, to stand, to walk, to transfer, whether that is range of motion and PNF, proprioceptive patterns, if they're in the ICU, whether that is facilitating neuromuscular reawakening after a stroke. That's more of the acute side.
Okay.
And then that also translates into like skilled nursing home care um, through the transitional care that is available to people. So that's like an elderly person who has a fall and isn't safe to go home yet. So they would go there and work on rehabbing themselves, or not themselves, but work with a therapist to rehab through all the different therapies to be able to be independently functional at home and safe. So a lot of people think physical therapy is strength because the outpatient world is so heavily dictated by insurance. And I'm just going to call it as it is.
Yeah. Fair.
I feel like it has dumbed down our profession
Yeah.
and it has dumbed down the care that people get because it is, yes, you go to an outpatient clinic and you get a round of exercises and you do them, and the therapist is seeing 4 people in an hour. So they're seeing 18 people a day. How do you get that hands-on care? And that is being dictated by the or allowed by the insurance and dictated by money, plain
Yeah.
and simple. Um, and I have been grateful enough to always have worked one-on-one with patients. I did travel PT right out of PT school, which was ballsy.
Yeah.
But I did it, and I always made sure that I worked in clinics, and this was insurance-based clinics too,
Right.
um, that where I was one-on-one, because uh, and think about in a acute care, a hospital setting, you're one-on-one because that patient may fall, and
Mhm.
you're working on moving them out of compensation patterns. Well, the same thing happens in outpatient care. We create compensation patterns from injury. So it's not just about strengthening, it's about retraining the body to come back into homeostasis. It's neural patterning to then be able to function again, because the body has this innate ability to heal, this innate ability to remember. And yet it also has this really amazing skill to compensate so that it can't injure that one area again.
Yes. So it's
And
avoiding that area of injury and by repatterning.
yes.
Now, even before we get to that, I still think of 3 times 10. You're going to take your ankle. So if we do an ankle injury or a chronic
Mhm.
ankle injury, or maybe it's a grade 2. So for our listeners, grade 2 means the ligaments are pulled. They're not strong, but they're not torn, but they're stretched. And when Megan used the word proprioception, that's the positioning of where your joint knows you are in space without your eyes, because the eyes always seek the horizontal when the eyes are open. But if you close your eyes, that's where the balance comes in, and that's not driven by your balance system or your eyes from your brain. That's driven by receptors in your joints, and that's where the proprioceptors are. So you're retraining from the bottom up versus the top down.
Yeah, and it's also remembering that the Golgi tendons are also within the muscles. So that's another nervous system cell that helps with proprioception. So
Hmm?
it's not necessarily just what's in the joint, but it's also within that's the surrounding muscle. And so it's about finding synergy, about finding the ability for them to work together to
Right.
know where they're at in space in order to be able to function in day-to-day life.
Right. So now a patient's not going to go in and say, hey, physical therapist, how's my Golgi tendon?
No, no,
That's like
no.
asking, is your
And
refrigerator running? Go catch it.
and I think this is the question that everyone's asking. Then how do you know who's a good physical therapist?
Right. Right.
Right? How do
Exactly.
you know? And interesting story. My dad broke his clavicle this summer, falling off a
Collarbone,
four-wheeler.
collarbone for those.
Yep, sorry, collarbone,
No,
thank you.
no worries.
I got in my clinical mind. And he flipped himself off a four-wheeler
Excellent.
and like, go dad.
Yeah.
And they wanted to refer him to physical therapy. And he called me and asked the question, how do I know where to go?
Yeah.
And I was like, okay. Because being protective daughter, I'm like, just come see me. But I live 2 hours away. So that's not possible.
Right.
It's the question of, mm, A, what do they most commonly treat?
Okay.
Because most PTs will say they're generalists. I treat everything. Well, mm, okay, maybe, but okay.
Okay.
How how many years they've been practicing. Now, that's not always an indicator of how good they're gonna be or not, but it is an indicator of, those first 2 years of PT school, after PT school, you're just trying to figure it out. I'll be just plain honest with you, and I feel like that's every licensed practitioner. Those
Right.
first
That's
couple
why I still
years,
practice medicine. I haven't gotten it done right yet.
you're just trying to figure it out.
Exactly. Move along here. Nothing to see.
Yep. And then ask, like, what's the mentorship like? What is the clinic like? Like, are you guys talking case studies? Are you having conversation? Or if that's not an option, do you have a community that you do that with? Um, And then number 3, you gotta follow your gut. If you meet someone and you're like, "This person doesn't know what they're doing," or "I'm not sure," then go somewhere else. It's the same thing with a physician. And
Right,
so truly my best advice to people is like, yeah, there's all of like the skill stuff, but really truly, if you want someone on your care team, you have to click with them. You have to connect with them. And
right,
so if they do an eval and give you exercises and walk away, that's not going to be who you want to be. And you say, okay, I'm going to go find someone else.
right. So their first question, I would add a caveat to that first question, is gonna say, who's their insurance take, right? Because most people will stay within that system. I'm not saying that that's correct, but that's what we do.
Yeah.
And there's so many conversations we can have around that, but that's not our topic today. But
Nope.
I'm gonna
Nope.
gonna rein us both in from that, from our inherent right to have healthcare. Moving right along here. Okay. But so find out in your local community who has been liked, who your friends have liked and why, what their outcome has been. That might be a slightly different approach, but similar.
So yes, if you have that community.
Okay.
So, and that's where relying in on a community if you have that community. In my dad's case, he didn't have that community.
Okay.
And so then it's also reading reviews, quite
Oh
frankly.
yeah. Oh yeah, it's a good one. Yeah.
Reading Google reviews.
And I think the replies to the Google reviews are important because,
Mhm.
it's honest that most people who get dischuffed or not happy give the review. People are super happy they're on their way. They tend not to review, but it's also the reason why a review was placed.
Mhm.
What were they going for?
Mhm.
I even had one review of someone who hadn't seen me. It was just a spam. And so I was able to call that out and get that removed. So those types of things. And I think too, people look sometimes if it's in with a system or not. Sometimes their surgeon might refer them or their primary care physician might refer them. I know I developed really good, back in the day, really good relationships with my physical therapist. Why? Because I was interested, because that's
Mhm.
probably also my background in
Mhm.
being an osteopath. I don't think it was because I was a control enthusiast, but probably.
I don't know, we'll see, Mary.
Yeah, I think it was. That was part of it. All right, all right, all right. But that did push outcomes a certain way. I'll tell you what. And but in building that team together for collaboration was good because, and I welcomed the physical therapist calling me. So that's another thing too, is how much does a physical therapist collaborate or how comfortable do they feel uh, getting collaboration, which you talked about, amongst themselves, or who is their team that they're reaching out with.
Yeah,
Um,
and it's also something to remember too that there's different practice acts within different states too.
yeah, say
And
something about that.
yeah, so I am a Michigan native, but this is the first time I've practiced in Michigan in the 12 years of my career. I moved here from Oregon, and Oregon was a complete direct access state. We were able to see people without even collaborating with their physician uh, if they were not covered if they were not covered by Medicare or Medicaid. And obviously, I always push to collaborate with the physician and at least give the notes. But if the patient didn't feel comfortable with it or didn't want them to have it, then I didn't do it. And
Mhm.
so it's also being really aware of then as a practitioner, like you're part of the team. Like we're never independent, even in that type of state. And so I always tell patients, they're like, well, who do I go see? Can I go see this person or this person? And I'm like, if you feel like they're benefiting from them, okay, you need an entire team around you.
Yeah,
And if you feel like it's not benefiting you or it's hurting you, and I will be the first one to say if it's not benefiting you, then it may not be a good idea. But that care team is so important and working together as healthcare providers instead of saying, no, 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 just see this person, just see me. That to me is always a little bit of a red flag.
yeah. So here's a question: should physical therapy hurt?
Great question.
Yeah,
Sometimes yes, but here's the difference. It's learning the perception of what pain is. Is the pain feel injurious? Does the feel like the pain is causing injury? Or is it that good pain? And we all know what that good pain is. The
like
good soreness, the
like a
good stretch,
like
the
yeah.
the good ache, but if even like sharp can sometimes feel good. But if it's that like injury, like acute injury, stabbing on like, and it sets your nervous system onto alert, and your physical therapist cannot explain why that's happening to help you downregulate your nervous system, then physical therapy should not hurt.
Okay. Because I think of something like a frozen shoulder, and how we treat that is so different now than when I trained back in, it was after the horse and buggy, but so somewhere in there where, there we used to just we really pushed quite hard in the range of motion. And then it moved to manipulation under anesthetic. And then now we actually we did inject, not necessarily, we did steroids. I moved away from steroids and did prolotherapy, which is a whole, podcast in itself. And then I moved away from the joint to get to the joint that was frozen.
Yeah. Frozen shoulder is an interesting one. I actually have a lot of success treating frozen shoulder, which I know doesn't surprise you, Mary, and
Yeah,
you'll hear more about this in upcoming um, podcast episodes.
yeah.
Uh, there is a difference between stretching into someone's ability to tolerate the pain versus stretching to their end range and they can't breathe.
Okay.
And this is where the last several years of my practice, the nervous system is like the indicator of all of this. Whether we're putting someone into fight or flight, or whether they're able to be in that healing capacity of pain, but they're not trying to run away, they're not trying to fight, they're not freezing, they're not trying to disassociate, or they're not trying to fawn, like, oh no, it's okay, it's okay. It's really becoming a co-facilitator of their healing instead of me as the therapist being in charge of their healing.
Right. And so that brings us right into the autonomic nervous system, which for
Mhm.
folks, that's the vagus nerve. It's the big thing, one of the big things. But there's way more to it than the vagus. And I'm waving my fingers because of the Golgis of the, reticular activating system, because of the midbrain, because of the neural autonomic and the immune system and the fascia and peace on earth, goodwill towards men. I mean, this is a completely complex issue, and we can't dumb it down, and we can't, and it's to make it to simplify this is to take years of practice of something that's very complex and present it clearly.
Yeah, I think we can simplify it in language to patients for them to understand, but for a practitioner to put it into practice, we can't
Yeah.
really dumb it down. And that has been the difference between me and most other physical therapists is I am very aware of what the autonomic nervous system is doing.
Right.
And knowing that healing of our body and that innate ability to heal takes place when we're closer to the parasympathetic nervous
Yes.
system than the sympathetic, which parasympathetic is rest and digest,
Mhm.
sympathetic is fight or flight. And so that piece, and so you want to find a good PT versus an exceptional PT, that's what you're looking for.
Yeah.
Are they addressing the nervous system and your capacity to just handle your experience while you are with them? Which is why I say meet them. If
Yeah.
you don't feel safe and comfortable with them,
Yeah.
it's not, you may get results, but they may be subpar from what you were looking for.
Yeah. Now, let's go the other extreme, which I think is equally fascinating. Person has a knee replacement, they have no physical therapy. Say something about that. And it might be sassy, and that's okay.
Are you dumb?
That's okay. That's a good, fair question. Who's
um,
done the patient? They may not know because what they're doing, and this
yeah,
is my
I know,
experience and
I know.
observation as a physician, observing the patient, seeing another physician is, well, the specialist said I didn't need it. You're just family practice. I'm like, WTF and H.
So this is a trend that started about 5 or 7 years ago. There
Yeah,
was a study that came out regarding surgery, a rotator cuff surgeries, and it said that 5 years post surgery was no, or 5 years post surgery was no different whether they received physical therapy or whether they didn't receive physical therapy. And so what has happened is, so let me say that again.
I'm
So
rolling my eyes at the 5 year mark.
yeah. So the study again said that 5 years after a post rotator cuff repair, so shoulder surgery,
Mhm.
patient outcomes were no different with receiving physical therapy versus not receiving physical therapy.
Okay.
And
So what
so,
was the road up to the 5 years? What did they miss out on? What did they struggle with?
what
What
type of therapy did they get? Were
right.
they addressing the compensation patterns that happen after a rotator cuff surgery? My guess is no. And the reason I can say
Before,
that, though,
how about before that caused them, if it wasn't an acute injury, if it was chronic?
well, if it was chronic, then we have built those compensation patterns have been wired and ingrained into the nervous system because what fires together wires together.
Right.
And so if it was a chronic shoulder injury, okay, so you go to lift your arm, oh, okay, here, now we got a shoulder shrug compensation pattern. And
Right.
then after surgery, if the therapist is not being super cognizant about getting range of motion while keeping that shoulder down, and then the patient isn't super diligent about retraining themselves, because I'll be really honest with you all here. This is a lot of work for the patient because behavior change requires conscious thought while you're moving
Awareness.
and awareness.
Yeah.
I mean, the graph of behavior change is you're unconsciously incompetent to consciously incompetent, knowing that you're not doing it right, to consciously competent, meaning you have to think about it to do it right, to then unconsciously competent, meaning, oh, now you can do it without thinking about it. But
Yeah.
the bridge to get there is you have to think about it. And then you have to do it right over and over and over again.
And you have to not be in the autonomic fight or flight sympathetic response. You have to
Bingo.
be in the relaxation response, which is
Bingo.
where all healing and forward executive functioning occurs.
Mhm. And I'll be really honest with you all here. Like, as a new therapist, I was that person post surgery, post knee, pushing them to end range, no matter what their pain was, because that's what I was taught. But I
Right.
quickly saw, and maybe this is like my empathy, like uber heightened, that they were just wincing and didn't want to come in. And I was like, huh, I wonder if I just take them to their end range and then get them comfortable and feel safe with me. And then maybe we can nudge a little bit further. And while we didn't see a lot of progress within a session to session, we saw a ton of progress because patients were adhering. They were doing their home exercise program because they were like, oh, this isn't excruciating.
Right. The other thing I wonder about that study of the 5 year outcome is whose idea was 5 years was the gold standard to figure out that that's what we measure. I mean,
Well,
we arrive at that measurement.
I don't know. And quite frankly, I read the study very quickly and I was so pissed off about it that I threw it away. And I wish I kept it because I also want to know who did the study.
Yeah, we'll have to dig that one out for further discussion because I've got thoughts on that one too. Because that's the thing too about, the studies. We have to look at the quality of the studies.
Mhm.
What are not only who's doing them, how long they did it. There's so many things on that one
Yeah,
too.
so many. And
Yeah,
so what's happening since then, Mary, is this is being extrapolated to total hips, total knees, like
yeah.
all sorts of surgeries. And I just also have to think that it's also maybe coming from the insurance company a little bit because,
Oh, it has to be because they're the patients are out of the hospital and a total knee can be an outpatient procedure now.
yep.
And a hip can be maybe an overnight, maybe two, depending upon the comorbidities,
Hmm.
but nearly almost an outpatient as well, depending on if they do an anterior posterior
Hmm.
approach and how young and healthy the person is, or what we would consider the comorbidities.
Mhm.
So I think there is a lot that goes into that. I think of, when I think of the tissue around the joint, because you certainly going in the front of the hip is easier than going in the back because the incision's smaller. You got to, avoid the big vessels of the iliac and the femoral artery, vein and nerve and the lymph. So there's a little more, you have to be cleaner. The back is you can be a little sloppier back there, as it were. Sorry, surgeons, if I'm calling you sloppy, not mean to, but I've trained a lot in orthopedics and was going to be an orthopedic surgeon and decided not to because I wanted to sleep instead of being
Well, and I have witnessed several anterior and posterior approaches, and I would agree with you. There's a lot more precision on an anterior approach than a
yeah,
posterior approach.
yeah,
Um,
for sure. Yeah.
yeah.
And so there's a lot less tissue trauma in the anterior
Mhm.
approach. That's the whole key with a smaller window. But you're still disrupting the capsule. You're still disrupting the proprioception. You're still putting a metal implant of some type, titanium, et cetera, in, and that's changing literally the both the anatomy and the physiology of that joint. I don't even know how we could arrive at not retraining that joint and retraining the person.
And I think this is the misperception of physical therapy. And I don't know where this happened, where physical therapists are just exercise people, because we're not.
Yeah.
And well, you can just strengthen yourself on your own. And I don't know at what point or when this perception came in, because I went to Duke. I went to a really good school. That was never my experience in school.
Right.
It was never my experience where, oh, someone comes to you for knee pain and you don't look at the core and the hip and the ankle. Like you always look up the chain and down the chain. That's how I was trained. But then in working with other PTs, especially new PTs and even older PTs, they never did that. So I don't know at what point our profession did this disservice to ourselves,
Hmm.
because truly a total joint is trauma to the body. It's no different than a car accident. It's an
Right.
elective trauma,
Yeah,
which
it's controlled trauma. Surgery is
yeah.
always controlled trauma.
And so you're changing, coming back to the autonomic nervous system,
Right.
you are changing how your body is going to fire and function and
Yeah.
move, because there's pain after a surgery that
Yeah.
will create compensation patterns to avoid that pain.
And then there's even just fear.
Mhm.
I
Which
mean,
is,
I
I
can't,
think, I
yeah.
mean, thank you for bringing that up, Mary. I think fear is the strongest compensation pattern and
Yeah.
ingrainer to really ingrain these compensation patterns because it's survival. Our brain wants us to survive.
Yeah. I can't imagine what an artificial joint feels like because it's artificial. And I mean, and I say that from a body awareness position. As a physician, I'm an empath. I'm a medical intuitive. I'm there. I can feel things. I can feel
Mhm.
things in other people. I certainly feel what I feel in my body, right? I can't imagine. And I think of myself skiing down a hill or a mountain, rather, I call it a hill, and going, I wonder what it would feel like to not know what my joint is doing, because it's just different. I can't, and so it's fascinating to me to think about stuff like that, of what people actually feel. What they say, what they report. My mom had, we had a nickname for my mom, Titanium Nini. Her nickname was Nini for Henrietta, and she had both hips done. So we called her Titanium. She didn't mind. but but she had so much hip pain that really translated into her sacrum, which is a whole nother, episode, that when her hips were done and she was out of pain, she was so mobile and just so free. And I said, well, what do your hips feel like? She goes, they don't feel. I don't have pain. But she also said that statement, I don't feel.
Mhm.
So that's interesting.
Yeah, yeah, and it's also just a huge indicator of pain and
Yeah.
that fear of pain and how it will change it will change your movement patterns. And then the reliance on the Golgi tendons, not to bring them back again.
Loving out to the Golgis. Not to be confused with goji berries.
Yes. But then the proprioception required within the muscle, but you're still missing that proprioception within the joint.
Yes.
So building that capacity and that awareness.
Yes. And so we build proprioception, folks, by balance. We
Mhm.
build it by standing on one leg or standing on two legs with your eyes closed or one leg with your eyes closed or on kind of a half a ball. I mean, there's graduated ways to retrain your body. So what I'm hearing is find a physical therapist, push for physical therapy. Don't just accept the status quo if you really want to return to full function. And I would dare say ahead of 5 years. So you can be a non-qualifier for that study because you've fully recovered much sooner and don't meet those standards of 5 years. But and I don't know why I'm being so cheeky about this today, but I think it just makes me kind of chuckle about. I agree, the dumbing down of this, and it's such an important thing to rehab fully
Mhm.
and to check around, find good therapists. If you don't feel comfortable and they're just saying, drop and give me 5, or here's a dumbbell, or here's a kettlebell, or here's an ankle weight. I know you might be there with a lower, extremity injury and you can't run quickly away, but move quickly away from
Yeah, yep. And as you're speaking, Mary, just another quick tip for everybody. A really good therapist isn't going to give you sets and reps and make you adhere to them because they're going to have you be feeling what you're feeling in your body. And you're going to do reps to fatigue or reps that are only in good form. Or so that's another indicator. Thank you for bringing that up and reminding me on that one.
Yeah. Okay, good. All right. So I think we've got more to discuss here because we haven't even scratched the surface.
No.
And I think that this is really important because it's going to really we're going to go into the land of chronic pain. We're going to go into the land of how chronic pain is managed in our complex medical system, our medical industrial system, how it's handled in our pharmacological medical industrial system, how it's handled in our psychological medical industrial. We're going to go everywhere with this over
Mhm.
time.
Mhm.
So this is going to be, something that we're going to keep returning to. And then I think it'll be fun to do some specific injuries,
Mhm.
specific rehabs, even talking about some stroke, coming back from that, what could be expected,
Mhm.
ankles, rotator cuff, I think is super important.
Sciatica
Sciatica,
and the different types of sciatica because it's not always from your back.
right. Oh, fascinating. Okay. All right. And this is, my ballywick because I did all the stuff I came up through and being an osteopath. We just sat around and talked about this all the time. And this is why I didn't become, one of the reasons I didn't become a surgeon because I spent so much time helping patients avoid surgery that
Mhm.
I was a competing intention to my own self.
Mhm.
So just went the other way.
Yeah. I just also want to say out there, total joint replacement, that surgery is cool. Like to be
Mhm.
able to be in excruciating pain and not be able to walk
For
or
sure.
function and then have that and go through good rehab and have
For
this
sure.
whole capacity and new life back. So I do want to make that really clear that I'm not like,
For sure. And my mom attested to that for sure. And she had a rotator cuff repair as well. So
yeah.
she's, yes, I just have memories of her being under anesthetic. We won't go there out of respect because she's passed. So I will hold those stories.
Mhm. So there is a place for the Western industrial medical complex.
Absolutely.
And then there is a place to know where to advocate for yourself to
Yeah.
get the best care that is available to you.
Yes. All right. Well, on that note, we're going to hold and have you come back to tell us more about many other things that we're going to talk about. So I want to thank our listeners for tuning in to Since You Put It That Way. This is episode 1.0 of Physical Therapy. Here we go. And our guest has been Dr. Megan Pass, who is a physical therapist here in West Michigan. And go to our website. We've got her information. You can reach out to her to consider some physical therapy with her and consider working with her and getting more of your questions answered. And thank you very much, listeners, for tuning in today. And we'll see you in our next episode. Thank you for joining us on the Since You Put It That Way podcast. Today's episode was written and produced by Crowded Table Productions. Technical editing, Malin Long Lopes. Sound editing, Jonathan Fiegel. Music, The River Jordan, written and performed by May Erlewine. Please rate and review our podcast as well. We appreciate your feedback, and hey, be positive, share the love.